Hello friends, today we are doing a group discussion about pathologies in shoulder and the shoulder procedures or shoulder surgeries that we routinely do. So with me are Dr. Akash, Dr. Shashank and Dr. Anil, and they will be discussing about various shoulder pathologies. So let's start the group discussion and we will be covering various kinds of shoulder pathologies.
Sir, how much, with my specific case, if a patient presents to us in a OPD with the clinical symptoms, but we get an MRI done and we see only a partial tear, approximately less than 3 mm of tear. So how would you like to approach? We should go for a scopy or we should manage a conservative?
So a partial tear is one subgroup of patient in which we are very much reluctant to do a surgical procedure. So we need to see and evaluate the MRI as well as see the clinical picture. So many a times these partial rotator cuff tear patients, they will be stiff as well. So most of the times the treatment will be physiotherapy and rehabilitation. Now coming to the partial rotator cuff tear, there are three spectrum. You can have a partial articular-sided, you can have a partial laminar and partial bursal, partial interstitial or partial bursal. So usually we would like to operate only those patients who are more than 50%, one, and that too if they are on the bursal side, then we are more aggressive in doing the arthroscopic procedure. So by and large, less than, so because the footprint of the rotator cuff is around 2 centimeters. So if less than 1 centimeter is, then we are anyway going to be on conservative side. But if it is more than a centimeter of the footprint which is exposed, then you may consider a surgical intervention, and that too after a failed conservative management. More indicated, arthroscopy is more indicated for a bursal than for an articular, and specifically indicated if the patient has got a good range of motion and still he has pain. So partial bursal side tear will be more commonly seen with impingement phenomenon, external impingement with a bony spur, whereas the partial articular or the partial pasta lesion will be more commonly seen with the internal impingement. And internal impingement is usually seen in throwers along with a contracture. So they will have a posterior capsular contracture, that is called as a PICC, that is posterior inferior capsular contraction, and these patients will have internal impingement. These patients have to be treated non-operatively with internal rotation stretching programs. So we'll ask the patient to do internal rotation stretching exercise more and more so as to reduce the internal impingement, and only if it is not successful after 3 to 6 months of rigorous physiotherapy, only then you will entertain and arthroscopic procedures for that.
Second question, sir. My same old age patient comes to our OPD with a complaint, and we have diagnosed it as a rotator cuff tear. So how we should counsel the patient regarding that if the rotator cuff is very massive and it is not repairable. So how should we counsel the patient?
So the most important thing is we should do a clinical examination, MRI. The thing we forget is X-ray. So always get an X-ray of these patients, and if the acromiohumeral distance is reduced, then it is an indirect indicator of a large or a massive cuff tear. So if the distance is less than 6 millimeters, it is an indication that the cuff will be massive, and I would not recommend a repair of the patient if the humeral head is touching the acromion. So if it is touching, then it is a sign of rotator cuff arthropathy which is setting in, and those patients would probably need a reverse shoulder replacement. But then you should have a very good view. Occasionally the view is oblique or some axial view. So you should have a good standing AP view, and on that, if the humeral head is touching the acromion, you should not attempt a repair. If there is a gap of about 5 to 6 millimeter, you can still do a repair, and in these cases you have to be prepared for all the techniques of the massive cuff repairs. Now per se age is not a criteria, even if you can do good repairs in a higher age group also. And the other thing is chronicity also. So if it is a fresh tear, it will be easier to repair. If it is a chronic, long-standing tear, it may be difficult to repair in some cases.
How should we counsel the patient regarding this case? Do we go into the repair, arthroscopic repair, or we just counsel regarding that it is not repairable? We have to.
So if you see the MRI.
Yes, sir.
So X-ray picture, if you have some space,
Yes,
and on MRI you feel that there is some tendon which is left and which you can repair. So you can ask the patient that we will be taking for scopy and we will be trying to repair it. we'll be using the techniques of massive rotator cuff repair like medialization, like interval slides, like releases, capsular releases. Occasionally we can do a muscle slide procedure also, but everything we will do to repair it. Now, as Burkhardt says that even if you are able to do partial cuff repairs in these scenarios, these patients will do well. And the important thing is the force couple. Now, what is force couple? Is you need to balance the forces. So if the rotator cuff is torn from posterior aspect or anterior aspect, so it makes the shoulder unstable. So even if you are able to repair subscap part and anterior part of the supra, or if there is a posterior tear, you are able to repair the posterior infra. So they will make the shoulder balanced, and a balanced shoulder will last for long. An imbalanced shoulder, so if the shoulder is having an anterior superior cuff tear or a posterior superior cuff tear, they will do bad. But if you are able to balance the forces, the force couple, if you are able to balance it, they will have a longevity which is more. So even if you are able to repair part of the cuff, it is good and it is worthwhile to do a repair.
So is there any role of acromioplasty while we are doing cuff repair?
Yes, so actually acromioplasty is indicated if you have a type 3 acromion, type C acromion.
Yes.
And typically it may be needed without a rotator cuff in those patients who have a large impingement. So normally what we do is we do the repairs, and if after the repair we feel that the acromion is tight and we are not able to move our instruments easily after the repair, then we take out a part of that acromion. So the amount of the acromion which is excised has now decreased over time. So previously people used to do very aggressive acromioplasty. Now we are doing a little bit less of acromioplasty. But still after repair, if you feel that it is tight and it is impinging on the cuff, it is always better to remove that part of the acromion. Occasionally you may need to remove a part of the distal clavicle also if there is a spur on that portion. So acromion and distal clavicle spurs you can remove if it is impinging on the cuff.
Sir, how we decide the space is narrow?
In arthroscopy?
Yes, by arthroscopy.
So arthroscopy you do a repair,
Yes, sir.
and after that your shaver is around 4 millimeters. And the RF probe is also around 4 millimeters. So that should pass out easily. If it is tight, it is not able to pass, then better to release it. About 6 millimeters of space is what is recommended. You should.
And sir, regarding subacromial decompression, should we do it like on a regular basis in older patient, in older age group?
So if you have an impinging acromion, you can do it. But as I told you, the amount of bone that we resect is reducing over time. So previously we used to do very aggressive acromioplasties. Now we are not that aggressive on removal of the bones.
Sir, how do you go about the biceps lesion, like to do tenotomy or tenodesis along with? So it's more of like a clinical examination in the patient, or depending upon the type of the lesion?
More on the scopy actually. Clinical examination is one. If you have a biceps lesion which is evident on the arthroscopy findings, which may include fraying, which may include split in the biceps tendon, ideally you should address it. Usually more than 60 years of age, we would try to do a tenotomy. Less than that, in a heavy worker, you can consider a tenodesis. The third procedure that we are doing nowadays is a biceps SCR. So we are utilizing the biceps, lateralizing it. But for doing a biceps SCR, you need to have a biceps that is relatively normal. So it should not have tears, it should not have a big splits, it should not have a large lesions per se.
Sir, what are your tips and tricks if as the bone hair, like if the tear is large and massive and the bone hair is more osteoporotic,
Yes.
along with have some kind of calcinosis deposition along with. So what is something that we need to take care when we go for a fixation?
So it is a very important question because Indian patients will have a very high incidence of osteoporosis and you can have tendon pull-ups.
Yes.
So what we do here, you must have seen, is we are starting normally with a 4.75 anchor. Most of the cases we are using a 4.75 anchor, peak anchor. If you are not able to get a good hold, you can increase it to 5.5 and then you can increase it to 6.5. Similarly, for the LR anchor also, you should have a backup of 6.5 anchor. So mostly we are using LR anchor 5.5, but if you need, you may need to have a 6.5 backup. So using a larger anchor is one technique. Using a buddy anchor is another technique. If you put an anchor and if you feel that the anchor is not strong enough, in the same hole you can put one more anchor. That is called as a buddy anchor technique. So that is a second technique. And the third technique which is described, which is not very commonly used, is cementing of the anchor. So you can use a bone cement and you can put it. There is a technique which is that you put it through a tube, and over the anchor you put the cement in, so that cement heats up into the anchor. But the negative part is that it prevents the biology. So it burns out the nearby area and it reduces the biological area. But that is the last resort that I will go into, cementing the anchor into the bone. That is the last technique that we can for osteoporosis.
Sir, is there any difference, like if depend on the type of the tear, the portals we use for seeing that?
Yes. So we start with the posterior portal, and most of the anterior and the subscap work and the anterior part of the subscap you can address with that. But if you have a posterior superior tear, like you have an infra tear or a TD spinous tear, it is better to make it a more posterolateral or a lateral portal, so that you can go on the back side. So more posterior anchors if you have anterior tear, and more anterior portals if you have posterior tears, lateral or anterior lateral portals.
So one more question regarding how do we, sir, what is the disadvantage for using the fluid which causes the extravasation in the deltoid muscle on the.
So by and large, I am not a very big fan of using a pump in the shoulder. So we usually do our scopies without pump, and that keeps our pressure low and prevents the extravasation. That is number one. The other thing is you should try to keep one track. So like if you are doing multiple tracks, or you are subcutaneously you are pumping multiple tracks, then it is a more chance of doing a extravasation. So, and the third thing is you can use cannulas. So different type of cannulas if you are using, so that also prevents extravasation.
Cannula through that portal throughout the procedure.
So occasionally we do it without the
Yes,
cannula,
we do.
and the benefit of that is the Bernoulli's theorem, that you can do everything without a cannula, but if you put the cannula, you will be reducing the flow and containing the. So you can do it both the ways.
So for the rotator cuff repairs, how do you decide if you want to go for a single row repair or a double row repair?
So if you see biologically, the double row repairs do well. But the negative thing of double row repair, there is one side effect or one complication, and that is called as a musculotendinous tear. So what happens is when you do a double row repair, you tie on the middle part and then you pull it and you tie on the other side. So what it causes the avascularity at the musculotendinous junction, and you may have tears on that. So if you have a very massive tear, and if you are pulling it under too much tension, that may cause a musculotendinous tear. So don't repair under tension. So whatever repair you do, it should be a tension-free repair, and you can utilize it to reduce the tension. So I would do double row repair in most of the cases, apart from very small tears in which a little part of the footprint is exposed. So one single anchor, single row is fine. And a very massive tear where it is not possible to do a full footprint repair. So there you can just do a single row repair and at less tension, that is okay. So otherwise, most of the routine cases, it is recommended to have a double row for a area healing. So single row basically is a point healing, and double row is two anchors, so it is an area healing. So the biological healing is better in a double row technique.
How much can we medialize that?
Approximately you can medialize up to a centimeter. Up to a centimeter.
Is there any landmark like we can see there and?
But you can just, because you need to erode the cartilage.
Yes.
So you can remove the cartilage